Right, good morning and good afternoon, everyone. Thanks for joining this ACED MCRC workshop. So the topic of today's workshop is the use of routine healthcare data for research on cancer early detection. My name is Niels. I'm Professor of Health Informatics at the University of Manchester. I also lead the digital health domain across the University of Manchester. And I'm involved in the ACED work that's going on in Manchester and the Manchester Cancer Research Centre. We've got a packed program for the next 2 hours. Could I ask you, just in terms of housekeeping, to stay on mute and keep your cameras shut off so that we can use all the bandwidth in the most optimal way. If you have any questions, please enter them into the chat and we will then pick them up as soon as possible. What we're going to do today is start with two general talks about the use of routine healthcare data for research in general, but then also specifically for cancer early detection in the UK and the US. And that is going to be followed by 3 shorter talks that are more specific. And we're going to have time for discussion after the 2 longer talks in first instance, and then also more towards the end. We've got another 15 minutes for discussion. So without further ado, I'm going to start with my own talk, which is going to tell you a little bit about the use of routine healthcare data for research in the UK, including cancer early detection. So what I'm going to do is explain in general what routine healthcare can do, what we can do with it in terms of research, also what the limitations are, some of the challenges that we have around fragmentation of the data, legal and ethical issues, and something that is called the electronic phenotype, the reconstructing of the phenotypes. I will say something about routine data resources that exist in the UK, mindful that we have people from across the Atlantic who might not know the landscape as well as people do from the UK. And I'm going to say a little bit towards the end about cancer early detection studies that have been done in the UK with these routine data resources. So, as you're all aware, the research data landscape has been changing quite tremendously over the last decades. And where we traditionally used to have merely data from trials, case control studies and cohort studies for research, that's been supplemented many other forms of data that we can nowadays use. Today, we're going to focus on that pinnacle in the middle there, the routine care data, by which we mean data from audits and registries, administrative data, and electronic health records. So what are routine care data? As I mentioned, electronic health records, insurance claims, and other administrative data that were recorded during the provision of health care. And they typically come in a variety of different forms. So the most common form for both electronic health records and insurance claims, etc., would be structured or coded data. So that's essentially codes taken from some structured vocabulary like SNOMED or ICD or the READ coding system. And each of the records then describes a small transaction between a patient and the healthcare system. So for instance, interactions with providers. So primary care and hospital outpatient consultations, accident and emergency visits, hospital admissions, but also things like diagnosis, prescriptions. So for instance, for primary care in the UK, we've got all the prescriptions coded electronically, 100%. Procedures that were carried out, referrals, lab results, and also clinical findings and measurements, although the quality of that typically varies. Beyond that, we can also have free text in routine care data. So for instance, the clinical narrative, letters, radiology and pathology reports. Access to free text is usually a lot more complicated, if it is possible at all, than for structured data. It is obviously a very rich source of information, but it's hard to get access to it for research purposes. Beyond that, we might have images and signals available in routine care data. So looking at the UK, what can we say about the availability of routine care data? So first thing to note is that obviously in the UK, we've got a universal healthcare system, the NHS, which is free at the point of service and has a unique identifier for each patient, their NHS number. Now, in terms of using routine care data for research, that's fantastic. So we've got more than 90% of citizens that are registered with the GP. So we've got really good population coverage. And that unique identifier makes it possible to track people as they engage with different services. So fantastic situation. Then all the GPs have used electronic health records now for more than 20 years, some even more than 30 years. So that's another piece of good news. And across the country, we only have 3 system suppliers for primary care and 4 systems. And they're all quite similar, really, in terms of the data, because they all have used so far read coding. In the future, that's now being replaced by SNOMED coding. So there's uniformity in the way that the coded data are recorded. And there's also, there exist incentives for GPs to make sure that the records of people with long-term conditions are of good quality. That's called the Quality and Outcomes Framework. So that means that we can usually assume that the data is of reasonable or even high quality. In hospitals, the situation is quite different. Electronic patient records are increasingly being used in hospitals, but certainly not across the board. That means that we have much less electronic information from hospitals. There exists something called the Hospital Episode Statistics, that's ICD-10 coding of hospital admissions. It's administrative data, not a care record. That's very high level, not very granular. For more granular data, there are no standards, and there are a variety of different systems that are being used. So this area is, I would say, a little bit more challenging compared to primary care. So what are the benefits if we want to use electronic health record data or other routine data for research? So I think there are a number of benefits. So the first is that we have the opportunity to have representative real-world populations, more than I would say in any other type of study. We typically have very large cohort sizes. We also have always longitudinal data. Every electronic health record is longitudinal by its very nature. And then we also have very long follow-up times. So like I said, in UK primary care, records now go back 20 to 30 years. That's really very, very long. And then they typically are available against very low cost because they're already there. The only thing we need to do is to query that record and analyze it. So compared to any prospective study, that is, it's available against extremely low cost. So just an example of what we can do with these kinds of data, and this is not from the UK, and it's also not about cancer early detection, but I think it's a really good example. I've always found it a really good example of the types of things you can do with routine care data. So this was a study published in the BMJ 7 years ago now from Australia, and they used data from the Australian Medicare system, which has records of health services for all Australians. And they used that to identify patients, people who were exposed to CT scanning. And the data were then linked to the Australian Cancer Database and the National Death Index, and used to find out whether and to what extent CT scanning increased the risk of cancer. Now, obviously, we always knew that it would increase the risk of cancer a little bit because it involves radiation. But before this study, there had actually been no real-world study investigating that. So this was a first, and it was quite large. So they used data from 11 million Australians with a mean follow-up after exposure of 9.5 years, and found that the overall cancer incidence was 24% greater for people exposed to CT scanning. So that's an odds ratio of 1.24, which is not too much. I think the good thing of this study is that we now know what CT scanning actually does to your cancer risk. And this was corrected for age, sex, and year of birth. So I think this study illustrates nicely what the kinds of things that we can do with these routine care data. So very large cohort, very large follow-up times, and a type of study that you would never be able to do on an experimental basis. So having seen the benefits, what are the limitations? So with these data, we're always stuck with a retrospective cohort design or a case control design, because there was no protocol for either the clinical management or the data collection. The fact that we are stuck with these designs means that there's always confounding going on. So in the previous study that I just showed you, confounding was obviously one of the big issues. The researchers did a lot to trying to deal with that in the right way. But it's always hard, and it's always hard to make any causal inferences from these data. And then the data were not collected for research. So that means that from a research perspective, the data will always be highly incomplete. From a direct care perspective, they were probably complete. They were good enough. But from our perspective, from the perspective of researchers, they will always be highly incomplete. And for instance, we will typically always have highly variable follow-up times. We're going to have selection biases. So there are, for instance, groups that tend to not attend, not to go to the doctor. So we will not see them, right? If you don't go to the doctor, you haven't got a health record. So they will be invisible in our studies. So that's a selection bias. We'll also have quite variable data quality. So a good example is strokes, for instance, in primary care. They tend to be coded in with not too much depth. So you very often find that the code doesn't tell you whether it's actually an ischemic or an hemorrhagic stroke. From a clinical perspective, that's so important, but the codes very often won't tell you. Just a little bit about those biases that we might have when we use electronic health records. And this one is a trap that many people have actually fallen into. So if we select people who have, say, 2 blood pressure measurements in their record, which seems a reasonable thing to do if you're interested in blood pressure or hypertension, what you're actually doing is then selecting the sick population, because those who do not have such a measurement in their record are probably less sick than the ones who do have such a measurement. So you have to be really, really careful with making these kinds of selections when you're using electronic health record data. And this particular bias is called informed presence bias, and epidemiologists have already started developing methods to deal with this phenomenon. So here's a paper from Journal of Epidemiology, American Journal of Epidemiology, that presents a method to deal with this particular type of bias. And this is a very active field of research. So what are the challenges when we want to use these data for research? I think there are 3 beyond the ones I've mentioned around biases and data quality, which are the fact that the data are very often fragmented. There are legal and ethical issues related to that. And we've got a challenge around phenotyping, the reconstruction of the phenotypes. So the fragmented data relates to the fact that, very often a single individual, in this case, Joe, would visit both their general practice, but also every once in a while a local hospital perhaps, and sometimes a tertiary care center. Now, each of these providers will have a separate electronic health record database or an electronic patient record database. And very often those databases do not interact with each other. They're not linked. So we've got 3 different data stores with information about Joe. Now, if we want to know more about Joe and get a complete picture of what's going on with Joe's health, we need to bring those databases together. So we need to find a way to link the data across these different sources. Now, looking at the legal and ethical side of things, in the UK, essentially this is covered by the UK Common Law Duty of Confidentiality and the UK Data Protection Act of 2018. And the Data Protection Act says that as long as we de-identify data, health data, so remove anything that could identify people, names, NHS numbers, dates of birth, etc., then we don't need explicit consent from patients to use the data for secondary purposes. So anything beyond direct care. So that's good news. So in principle, health data are confidential data. We can only use them with consent. But if we make sure that we remove anything that would identify people, we actually can do it. And all we need is approval from the data controller. So that, for instance, would be a GP or the hospital. And that also means we don't even need research ethics approval. So we can just use the data once we have a data sharing agreement with the data controller. Now, the challenges come in when we start linking data. As I said before, very often we need to link data because the data are dispersed across different databases. And that means we have to retain something that would identify people. For instance, a pseudonym derived from the NHS number. And once we do that, we are breaking the law. So the only way around that is using something called Section 251 approval, which is provided by the HRA Confidentiality Advisory Group. And that's quite a complex procedure, and it could easily take 6 to 12 months in order to get that. But I think very often we have to link data, so this is the only way to do that. You'd still not need consent, so this is for unconsented data. So then the third challenge is around phenotyping. And this has to do with the fact that routine data are typically transactional in nature. So very, very different than the data that we are used to see in research. If we want to use them for research, we need to pull out the clinical phenotypes that we're interested in. And that's a very complex activity because we might look at a large number of different small transactions in order to infer what was actually going on with a person. So this is also a very active area of research in my field in informatics. And so this is from a presentation from Spiros Danexis from UCL, and I really liked the analogy here that Spiros drew, which is we could view the record, the raw data, as basically a box filled with all these small Lego blocks, and in order to reconstruct the phenotypes, we have to start searching through the box and put them together and find, the phenotype that was behind all those Lego blocks. Because that record, that box, it won't tell us. It has very little structure really, apart from time. So if we want to understand, for instance, that we're dealing with a patient with, say, type 2 diabetes and uncontrolled hypertension, we need to reconstruct that from the blocks. So that's the electronic phenotyping activity. More and more we see that there are tools now to help you do that, to do that electronic phenotyping step. And one of the tools I wanted to highlight is called GetSet. It was developed by one of my research fellows, Richard Williams, and it essentially helps you to create a set of clinical codes that all relate to the same phenotype, say something like type 2 diabetes. So it's a free tool, and you can find it on the web on this address, getset.ga. So routine data resources in the UK, I've got I've listed a number of resources that exist in the UK on the slide here. It's certainly not complete because there are many more, but these are probably the ones that are most well known. So there's a database called the Hospital Episode Statistics, which is an administrative database of all the hospital admissions in the UK. It's held by NHS Digital. Then probably best known is the Clinical Practice Research Data Link. That are English primary care records, only the structured data, not the free text or anything else, routinely linked to HES and the National Death Register from ONS. There are two flavors, two databases within CPRD, CPRD Gold, CPRD Aurum. So CPRD Aurum, that's 738 practices, 19.3 million patients, so it's really big. Then in Wales, we've got the Secure Anonymized Information Linkage Databank, the SAIL Databank, about 3 million people, very, very rich. So it's similar to CPRDs because the core is primary care records, but it's linked to many sources of administrative data. So I would say it's slightly richer perhaps than CPRD in that respect. And finally, the Biobank, the UK Biobank, longitudinal cohort, 500,000 volunteers aged 45 years and older. And for them, we've got questionnaire data, genotyping, imaging, HES, and also now, since 2 years, I think, primary care records. So I'm going to finish with a couple of slides about cancer early detection research using electronic health records in the UK. So this is a type of research that started in the mid-2000s. A couple of years back in mid-2018, there were about 50 studies in this area. I don't know how many there are now, probably a little bit more than those 50. And a lot of this research has underpinned the NICE guidelines that were published in 2015 for recognition and referral of people with suspected cancer in primary care. And I'm just going to highlight one study that was published in the British Journal of General Practice in 2018. So this was around early detection of multiple myeloma in primary care using blood tests. And this study used CPRD, so the Clinical Practice Research Data Link. It was a matched case control study, so there were 2,700 multiple myeloma cases identified in CPRD, and then more than 12,000 matched controls, matched by age, sex, and general practice. And then for each of those case and controls, the researchers looked back 5 years at the blood tests that were available in the records. What they found is that, contrary to what I think some people thought was the case, at least in primary care, raised plasma viscosity and ESR are not very good for detecting multiple myeloma. And sorry, they're better than C-reactive protein. So C-reactive protein isn't as good for detecting multiple myeloma in primary care. PV and ESR are better to do that. And also a combination of a normal ESR or PV and a normal hemoglobin is a very effective and simple way to rule out multiple myeloma in primary care. So just to summarize, routine healthcare data can be used for large epidemiological studies in real-world representative cohorts with long follow-up times. We are always limited to a retrospective cohort or case control design. The UK has vast resources of rich electronic health records, especially from primary care, a little bit less so from secondary care. We usually need to link records at patient level, and this creates some ethical and legal challenges. Routine data are not collected for research, so a key challenge is the reconstruction of the phenotypes, and the number of studies addressing early detection and diagnosis of cancer is growing. So thank you very much. And I'm going to hand over immediately to John Holmes, the next speaker, and after John's talk, who is going to look at the situation in the US, we're going to have 15 minutes for Q&A based on his talk and my talk. So give me a second here, John, because I want to properly introduce you.
Oh, okay, I can wait.
So John is a professor of medical informatics and epidemiology and associate director of the Institute for Biomedical Informatics at the Paramount School of Medicine of the University of Pennsylvania. And John is going to describe to us the distributed data environment in the US as it is used for clinical and population-based research, focusing on the early detection of cancer. And he will describe various sources of data, including electronic health records, insurance data, insurance claims, social data, and describe some of the challenges and opportunities that exist in the US for this type of research. So John, many thanks for joining, and
okay,
the floor
pleasure.
is all yours.
Okay, let me share my screen and take us on to the presentation. Okay. I trust everyone can see my slide.
Yes, we can.
Okay, great. So thank you, Niels. And just to let you know that actually Niels and I share a lot of interest in using secondary data for various and sundry purposes and the various methods that are associated with that. I'm going to focus primarily on sources right now, but talk about some of the characteristics of those sources as well. So I've identified 6 that I want to talk about. There are many more. And in fact, Niels mentioned social media data, and I'll talk a little bit about that at the end. But I want to talk about some of the more accessible sources of data in the US at this point. So we'll start with electronic health record data. These are typically available through a contractual arrangement with some health system typically. Like for example, could somebody come to the University of Pennsylvania with a funded study and say, look, or maybe they're putting in an application to do this study, and I'd like to use the data here. Is that possible? That's not impossible, actually. It could be done. But typically this is done in the context of a consortium, as I point out here, because the data are very much seen as proprietary. And you know, the problem here is that the privacy it really it applies to both patients and the entity and the associates of that entity. So, you know, we often think about patient privacy, and of course that's really primary, as Niels had pointed out, and it is in the US too. We have a thing called HIPAA, which many of you have known about, the Health Insurance Portability and Privacy Act, which just puts, you know, actually significant constraints on doing research from the way we used to do it pre-HIPAA. But then there's also the corporate or the entity privacy that needs to be maintained. If you're working with a number of different hospitals or even just one, and you're collecting data from their clinical data warehouse, and maybe they're not managing their diabetics as well as maybe somebody else should or would be, as evidenced perhaps by lab results like the hemoglobin A1C or other things, the entity doesn't want that information to get out. Not only that, but associates could be people like residents and fellows and faculty members, attending physicians, nurses, etc. Anybody who is working in that entity whose privacy could actually be breached during the course of using these data. So these all have to be approached very, very carefully. So for each one of these sources, by the way, I'm going to bring up and highlight the regulatory issues that are associated with each. Of course, there's HIPAA, as I mentioned before, and under HIPAA, we're very constrained in terms of the types of data that we can get. There is a list of 18 identifiers that we can't have data on without special, what is called authorization from the patient, who is represented by one or more of those 18 identifiers. And they include the typical things like name, address, phone number, but also things like URL. So the Uniform Resource Locator is definitely not allowed. Either is the IP address, and there are plenty of others in that list as well. So all of those, what we call direct identifiers, are really pretty much forbidden for us to have access to without special authorization from each and every patient who is represented in our data. And then on top of that, we have to have, and this is separate, by the way, we have to have approval from our institutional review board locally. Every institution, hospital, university, healthcare system has its own institutional review board, or in some cases they contract out to a commercial IRB. But the institutional review boards are very idiosyncratic for each institution or each instance. So you've seen one IRB, because that's actually a doctrine in the federal mandate here, the common rule, that the IRBs have autonomy within their own community. But you do have to get that approval, and it is separate from HIPAA. And in fact, many times there's a privacy board, which is separate from the IRB. And that's not the case at Penn. Our IRB is the privacy board as well. So we review the HIPAA applications as well as the IRB protocols. But then there's also the patient consent, which is a very important regulatory issue. And I should mention that Penn is not unlike many institutions in the US, where we have an opt-out clause on the consent for treatment. So when patients are being admitted to the hospital, or they are coming in for care to a new primary care or GP setting, then they're asked to sign a consent form, and they're notified on that consent form that their data, de-identified data, may be used in the future for research, and they can check the box to opt out of that. And so we know that, who those people are, and we will not get those types of data if we, in the course of these contractual agreements here, we will specify that we will not use those data at all. So that's our, our stringent regulatory issues for using electronic health record data. And something that often actually causes us a certain degree of I should say, not just difficulty, but also increased time in accessing the data and using these. Okay, just trying to get my mouse to work here again. There we go. Okay. So how about insurance claims data? As you know, we have a very rich and very extensive healthcare insurance enterprise here in the US. It's what really drives healthcare here. And so it's also very often a rich source of data for a number of different types of studies. But the data are limited to a claim for a good or a service of some type. But what you get from this is an enormous amount of data that includes a record for every single claim that would include their date, the type of claim, and the procedure or the diagnosis code that's associated with that claim. So we get these data from Medicare and Medicaid. Medicare is our insurance plan, basically, for people who are 65 and over, plus people who have certain conditions such as end-stage renal disease. Patients who are on dialysis will be put on Medicare regardless of their age. The same thing is true of patients with Lou Gehrig's disease or amyotrophic lateral sclerosis. The same thing there. Medicaid is a medical assistance program that is overseen by the federal government, but maintained and regulated by the states, that or administered by the states rather, that provides care to the indigent, meeting certain financial and other types of requirements. And, between these two, there are probably about 100 to 110 million people who are covered by one or two of these plans. And then, of course, there are the proprietary insurers. Cigna is one company, Optum is another, Aetna is yet another. There are plenty of these insurers that are out there. And of course, the so-called Blues, the Blue Cross and Blue Shield variants that are really rampant throughout the US. So there are regulatory issues here. As always, there's an IRB protocol that needs to be written, but there are also regulations specific to the vendors. So I'll speak to the Medicare and Medicaid data specifically, because in order to go through those, in order to get those data, you have to go through a series of hoops that can take quite a while to go through to access even de-identified data. So you will put in an application with a protocol. And you'll do this simultaneously with the IRB, because before releasing the data, they will want to see your IRB approved protocol. But then it goes through a research data center, or the ResDAC is what it's called, at University of Minnesota, is the primary administrator of this. And they're the ones who are really sort of administering the dispersal of these data. So it takes quite a while to get them, but once you do, it's incredibly rich. And you can get Medicaid data by state is typically how it's done. Medicare is much more of a federal database, but you can get that also by, stratified by state as well. So very, very useful for studies like pharmacoepidemiology, where anybody who will come in to a pharmacy who is covered by one of these plans will get a claim that would cover that the cost of that drug. And the same thing's true of perhaps of a preventive service, such as prostate-specific antigen test or a mammogram or a colonoscopy. Any of these types of screening and ultimately diagnostic tests as well will generate a claim in the insurance claims data. And you would be able to track, really see how many people are getting these tests versus how many are not. And by geographic region, you will also get some information about that as well. So pretty rich source of data and very useful. So another one, not to be overlooked here, is the Centers for Disease Control and Prevention runs the National Center for Health Statistics, which is an incredibly rich data warehouse is one way to look at this. They run a series of data systems within this warehouse. Vital statistics are there, birth and death certificates among them. And plenty of others as well. But of interest actually for early detection and diagnosis, the National Health Interview Survey, which is a health status survey, which is administered to a large proportion of the population on an annual basis. And especially the behavioral risk factor surveillance system, which is also a survey system administered to, and it's federally overseen, but it's actually administered by the states. And there are core items on there having specifically to do with cancer screening. And so seeing cancer screening as a behavioral risk factor would be, like an important, actually a body of research questions here, I would think, that, you can find out what people's attitudes and beliefs are about, for example, getting their PSA done for prostate cancer screening or other tests that they might have. So, and those specific questions are on there, actually. These data systems are totally free. They're publicly available. They're de-identified. There isn't any real regulatory issue here, except that the NCHF does forbid record linkage without permission. And it takes pretty much an act of Congress to get that permission, because, once you start linking these records together, along with other things, that might exist, such as some of the other data systems I'll talk about shortly, you run the risk of re-identifying people. So this is a one hoop that you have to go through to get to link these data, but by and large, they're going to be very useful for doing large-scale epidemiologic surveillance for ascertaining whether people are actually getting screened or not, and what their beliefs and attitudes are about that. Another one to look into is actually run by the National Cancer Institute here in the US, and they run the SEER program, the Surveillance Epidemiology and End Results Program. This is the authoritative source of information on cancer incidence and survival in the US. It goes back to 1973, and it is our only source of population-based historical as well as current information on patient survival and stage of disease. So this is patient-level data, actually, de-identified, but it's still patient-level. And there are 19 cancer registries that participate. That covers about 26% of the US population, which might not sound like much, but it's actually a very, very rich data set, or set of data, because it is available on an annual basis. There are some regulatory issues associated with this. First of all, there's a data use agreement that you have to sign and fax back to them, which is really quite minimal. You're just agreeing not to link the data to any other data source, and that you will not try to re-identify people. Of course, you need to have an IRB approval here. And in fact, it's one thing I should have stressed, that for any type of secondary data use, we always have these protocols looked at and approved by the IRB. And that approval could be that, yes, it needs a full board approval, or it's just, something that we're not considering to be human subjects research because it's de-identified data, it's publicly available. And that would very well be the case with SEER, except that you want to be able to say that in any publication, that you did have the IRB look at your protocol and they determined that this was not human subjects research. Then you're fine. But so we do require that all studies, regardless of what we think they might be, whether they we think they might be exempt, or they might require a full review or an expedited review. That's not up to us as researchers to determine. That's the IRB's job. And as I say here, record linkage requires permission. However, I just talked about Medicare. And in fact, there is a linked data set that was already pre-linked for you, the SEER Medicare data. Because so many of these patients are older, they find their way into claims in the Medicare database. And the thing is, a lot of patients are getting care outside of what is actually in the registry. So they might be going to another institution, for example, rather than the place where they're going for their cancer care. Then you would be able to link that with their Medicare claims records to find out what is actually going on, what drugs they're taking, what procedures they're having at other sites. So this isn't so much about early detection, but I bring this up primarily because of maybe early detection of such things as metastases, right? Or development of additional cancers that, you would be able to actually investigate with that type of a data set. And so early detection might be well, it is actually of great importance there. Okay, so the SEER data includes patient demographics, and primary tumor site, and the morphology and stage at diagnosis, the first course of treatment, and subsequent courses, and follow-up for vital status, a very rich data set. So how about the census? So being an epidemiologist, I'm always interested in denominators. And that's what we get at the census, right? We can get down to the census tract. We can find out all sorts of information stratified by sex, by age, by neighborhood, and neighborhood characteristics and the like. And these data are gathered through a number of different systems here. The American Community Survey collects data on about 3 million American households yearly. And stepping back a second, we usually think of the census as being a decennial type of enterprise. It happens every 10 years. And in fact, it's happening right now in the US, as you might have heard. But there are additional things that come out, additional surveys that come out periodically to give us estimates that in between those 10-year periods. So the ACS is one of them. Another one is the Population Estimates Program, which is very, very useful to give us as much up-to-date information about denominator data, like how many people actually live in this census tract, or how many people are at risk of a cancer. We can figure this out by looking at, well, these surveys can actually help us to figure this out. We have other data that we have to look at as well. And there are other surveys that you can see here which all come into play. There are no real regulatory issues, but you can't get person level data, current person level data, without essentially an act of Congress. I'm sort of joking here, but it's pretty difficult to get. But you can't get person level data if it's over 72 years of age, 72 years since the last census, or when that census was taken. So that you can get. So I would like to talk a bit about distributed research networks, because this sort of ties everything what I've been talking about up a little bit, especially with regard to EHR data. So we have a very active distributed research network climate or ecosystem in the US, which consists of multiple distributed research networks, each of which consists of multiple healthcare systems and hospitals and the like who contribute data to them. So in general, a DRN, a distributed research network, is a system that allows secure remote analysis of separate data, each derived from a different medical organizations or health plans records. So there are two that I'd like to mention here, and this is just two of many. There is the Observational Health Data Sciences and Informatics group or enterprise, which is called OHSU for short. And then there's PCORNet, the National Patient-Centered Clinical Research Network. So the regulatory issues associated with these are typically a central IRB, but sometimes a distributed IRB. Interestingly enough, as we take a look at the way OHSU works here, this really simplifies it very much. Where you have a source, let's say Hospital 1, Health System 2, and maybe another group over here is maybe a group of specialty practices. And these are all arranged in, or accessible rather, through a common data model, which requires these groups to actually send their data out adhering to this common data model. And I'll give you an example of what one looks like in just a second, not from OHSU, but from PCORnet. And what you end up is now data which is now adherent to the same data model, right, at each site. And now you can apply an analysis to each one of those. And then the results of those analyses come back, preserving the privacy and confidentiality of the patients at this level, at each of these 3 levels, right? But now those data have been transformed in such a way that it preserves the privacy and the confidentiality of the patients, but it still allows us to analyze the data in a meaningful way. And that includes even up to and including distributed logistic regression modeling and other sophisticated regression modeling methods, which people have worked on. So in PCORnet, a little more detail about this. Here you've got you're a researcher and you have a research question, and you would submit that question to the PCORnet Coordinating Center through something called the front door, which is a website essentially. And then the front door will send this electronically, your query, to the PCORnet Coordinating Center. And then that query, right, after being accepted by the coordinating center, and it will convert that question into something that can actually be used by other sites. So PCORnet is actually a very large conglomeration, as it were, of the clinical research networks, or CDRNs, as they're called, which that in and of themselves are networks. So PCORnet is actually a network of networks. So there are a number of different distributed research networks that band together to create PCORnet. So for example, there's one such distributed research, or CDRN, here in Philadelphia, based in Philadelphia, called PEDSnet, which is a group of 6 pediatric hospitals, specialty hospitals here in the US, and allow us to do a number of interesting studies, which we have done, looking actually at pediatric asthma, but it certainly could be used for cancer. But anyway, the query goes to the network, it gets distributed out, the analysis is run, and the response comes back to the coordinating center, back through the front door, and then back out to the researcher. So this is just one example of how these things work. And individually, the individual components of PCORnet are also accessible as well. As I mentioned, we use PEDSnet in this asthma study, but we're not using all of PCORnet for this, obviously, because we're interested in kids in that particular case. So here's what a common data model looks like. This is one from PCORnet. This is the current one from 5.1. Version 5.1. So there's demographic data, encounter data, diagnosis data, procedures, etc., drugs, both prescribing and dispensing, by the way. There's all sorts of information about, vital signs and causes of death, etc. You can see here it's pretty complete. These are the actual variable names that are required to be used in the queries that are sent through the coordinating center to the networks. And if they don't, well, then it's just not going to run. But everybody has agreed to, and this is also a regulatory issue, everybody who is participating, both in PCORnet, but as well, this applies as well to OHSU, they have agreed to participate in this enterprise by adhering to the common data model requirements. So that is the end of my slideshow, and I'll stop sharing right now. So Niels?
Yes, thanks very much, John. That was fantastic. And actually, we shouldn't go into politics, but it's quite interesting, I think, to see that in the US, things have been built up using this distributed or federated approach, whereas in the UK, we tend to centralize everything, right? So
because you have the NHS, and
yeah,
you have that whole ecosystem that's built up around the NHS. We don't have that as well. I mean, I just gave a talk on the healthcare system in the U.S. to a class in Pavia, Italy, in the hour before I came online with you all, and they were all horrified at the type of system we have here. So it is very difficult. It makes for real challenges, both regulatory, but just, like entering into negotiations with all these distributed groups can make life very difficult.
Yeah.
And by the way, I did say that I was going to mention something about social media social media data, we don't have to talk about it now, but that is a very important source of data for us in early cancer detection. I've used it myself for looking at beliefs and attitudes about prostate cancer screening. Not just social media data like the typical Facebook and Instagram and all of that, but also we did a study with some folks up at NYU looking at responses in the New York Times to editorials about changes to the screening recommendations that were from the U.S. Preventive Services Task Force. Back when they changed them several years ago and made it so that, no, you don't have to get a PSA every time you come in to see your doctor. You need to discuss it. And it actually engendered quite a bit of discussion, which was very interesting to see. So.
I'm going to hand over to Ali, who's going to moderate the discussion.
Yeah. Thank you both. That was really good. And I use routinely collected data in the UK, but there was still quite a lot I didn't know that's sort of changing and going forward. So there was a couple of things. We've got a quick poll that I think is going to flash up soon on your Zoom screen. That's just trying to get some information about what data people use, why they might not use it. So please feel free to take part in that. And also, if you don't want to, just click the red X button and get it off your screen. But just sort of while people are completing that, I've just wondered, you both touched on it, and it's an issue with routinely collected data, is that often we only collect information on people when they're sick. So although we have better generalizability than maybe an RCT, we sort of lose some of that because we don't have some of the other contextual information. And I wondered if you had any solutions to that or any comments on how that might change in the future about how we can use this data even though it might be biased.
Shall I go first, John?
Yeah.
So obviously we do have population denominators. So for instance, we can use it the lists of people who have registered at general practices. So some of the people on those lists, they might never have visited their GP actually, and never received a prescription, never had a lab test being done. But we know they're there, so we can count them, and we would normally count them as healthy people because they're not attending and there's no evidence that they are sick. That's obviously quite crude, but I would say for routine data, that's usually the best we can do. There are data of people who have done the NHS health check and might be perfectly healthy. So I think there are some data of people who are healthy in the GP record, but I have to add that that's relatively limited. So it doesn't have the coverage that we would have for other types of data.
Okay, thank you very much. John, is it similar in the US or?
It's no, because actually we don't have people, not everybody is registered with a health system. We have, unfortunately, many people who don't get care at all because they don't have a GP. They've never been to one, or they have been to one as maybe through, not a GP, but they've received healthcare through an emergency department. We have plenty of people who do that in the US, unfortunately. So what we can do though, is to, look at, if you're looking at EHR data, for example, I'm thinking about this more epidemiologically now, and Niels, you brought up the point of doing a retrospective cohort study. Well, you're always looking at the exposure then, right? So what is the exposure? The exposure could be maybe having had a screening test. And then you'll have people who were not exposed and they never had a screening test. And maybe you can stratify based on some certain risk factors so that we know, for example, that there's a very clear demographic that fits the compartment of somebody who is at high risk of early and late stage of diagnosis prostate disease. That person is typically an African American who has at least one first degree relative who has also been diagnosed, et cetera. So, and it's between the ages, actually, unfortunately, between 35 and 50 or so. So that person now is very different probably than somebody who is a Caucasian and doesn't have any, any family predisposition, et cetera. So you can look at that person as the unexposed. So, and you can stratify those people out. and then take a look at them, take a look in their records and see how many of those people have actually gotten their prostate specific antigen tested over the course of time. And that's, you know, and then how many people have actually gone on to develop a cancer. And there are so many people, unfortunately, in that first demographic that I just mentioned, who have been detected at late stage disease and have never had a PSA test. So their exposure, they were in the unexposed group, but now the exposure being the PSA, now they have unfortunately late stage disease. So we can do those kinds of studies, but within the context of a health system's EHR.
Mm-hmm.
That's the problem. We don't have the national system where we could do what Niels was suggesting, doing a population-based study like that. Be really tough to do.
Right.
Anything else we would do would be purely ecological. I mean, surely we've got denominator data from all the census, sources that I talked about here, but that's purely ecological.
Okay, I'm just going to pick up some of the questions in the chat. One of them was commenting on how difficult it is to get hold of these data sets for teaching purposes. So that if you're teaching medical students about how to enter data and what that looks like, it's very difficult to get hold of that information. And I don't know if you had any solutions or if you had any examples of how people have used this data for teaching purposes in the past, or how to get around this sort of thing.
Yeah, I agree. I saw that as well. That came from Ange and David. So yeah, I agree. It's a real challenge because we need to give people the skills to analyze the data, and especially because the data are so complex. It's very important that we do that. But it's hard because there are so many regulatory issues around giving people access that doing it just for training purposes is a real challenge. I think one solution could be synthetic data that are generated using the distributions that we see in the real data, and therefore would, be good enough, certainly, to help people to acquire the relevant skills.
Yeah, I would agree with that. The synthetic data is a really good option, and it doesn't require really doing much more than just talking to people, let's say at a health system or a hospital, to ask for distributions, so that then you can plug them into the software. The name of the most popular one just totally escaped me, but it has the word synth in it for obvious reasons. But it's, and it's freely available. It's actually, you can just download it. But we actually use data from our health system to teach in our informatics courses, but it's been completely de-identified. And any place where there would be the possibility of obtaining cell counts, in other words, small numbers, where you could potentially identify somebody with particular diagnoses because there are only 4 or 5 of them, and then you're looking at their age, which is not, by the way, unless you're over 80 years of age is not one of the 18 variables that's a problem, and it's not an identifier at all. Then you could conceivably re-identify somebody.
Mm-hmm.
But that's a great point. We've also, by the way, speaking of teaching, we have also taken data. There's a very well-known, it's not really great for cancer detection, but at least I don't think so, but for basic clinical purposes, the MIMIC-3 data set, and now MIMIC-4, which is a data on about 35 or so thousand ICU admissions up at this hospitals associated with Harvard. And you can download those data. You have to go through actually quite a process to get them. But once you get them, they're extraordinarily rich, both in structured and in unstructured data. And we've taken those data actually and plugged them into an electronic medical record system that's free. It's called OpenMRS, to allow our students to play with those data in a health system or in an EHR type of setting, so they can see what it's like to use them. So there are free and easily obtained data sources out there, either ones you make your own based on distributions, or that you can just download like Mimic. Yeah.
Thank you. Yeah, and I'm just aware of time, so there was just a couple of things I was going to summarize from the discussion we've had. I think that there's some quite interesting things about the distributed learning systems that will hopefully across ACE become something that we become quite good at. in the UK and the US about how we use these data with the different centres, and about the permissions that are easier to do if you're in the country, and linking across collaboratively is something I think could be quite powerful. I'm just going to share the results of the poll that we did, just out of interest. I think some of these are quite interesting. So hopefully you should be able to see this pop up. Not everybody's used routinely collected data, but a lot of people have. Nearly 80% of people think the data sets are suitable for early detection research, which is good. It means we've got different opportunities here. There are costs associated with accessing the data, and some people are aware of those and some people aren't. So if you're not, it can be a surprise when you put together a proposal and somebody sends you an invoice that's a lot more than you thought it might be. And what people think is the most prohibitive factor with these data sets, the highest option was data quality. And obviously a lot of people are concerned about ethics and how tricky those might be. But hopefully a situation like the ACE network, we could overcome a lot of these issues with our kind of collective knowledge. So I'm going to stop sharing those results, and I'm going to hand back to Niels, who's going to introduce the next three speakers, and hopefully there'll be some good examples of how people have done a lot of these different, answer a lot of questions about early detection research using data. Thank you both.
Right, thanks, Ali. Yes, so we're going to continue with three shorter talks from speakers from UCL, Cambridge, and OHSU. So I'm very pleased to introduce the first of these three speakers. That's Aleksandra Gentry-Maharaj from the MSc Clinical Trials Unit at UCL. So Alex is a Principal Research Fellow, works at the Clinical Trials Unit. Her main interests are ovarian and endometrial cancer screening, genetic predispositions to ovarian cancer, and cancer biomarkers. And she's going to give an overview of the UK collaborative trial of ovarian cancer screening, UK CTOX. So, Alex, the floor is yours.
Thank you so much. Thank you for inviting me to share the overview of the linked data that we have with the trial. So I'm going to just share my screen, and hopefully that will work well. Are my slides showing?
Yes, they are.
Yes, okay. Good afternoon, or good morning, or good evening, everyone. So what I'll be doing over the next 10 minutes or so, giving an overview of the trial and the linked data that we have, and exploring some of the successes, challenges, and opportunities as we go through the afternoon. So the United Kingdom Collaborative Trial of Ovarian Cancer Screening, or UK CTOX, is a randomized controlled trial which is aiming to assess whether screening has an impact on mortality from the disease. So between 2001 and 2005, 202,638 postmenopausal women who were aged 50 to 74 were recruited to the trial, and then they were randomized either to control arm, undergoing no screening, 101,000 women, or to screening with annual transvaginal ultrasound, 50,000 women, and the other 50,000 to an annual blood test, so CA125, interpreted using the risk ovarian cancer algorithm. So women in the screen arm were screened annually for 7 to 11 years until the end of December 2001. So each woman at recruitment provided written informed consent, and it was a broad consent for use of samples and data in ethically approved secondary studies, which will be more the subject of this talk. The women also completed a recruitment data sheet and had follow-up questionnaires completed 3 to 5 years post-recruitment, and then in 2014. But all women donated a blood sample at recruitment, and in the 50,000 who were randomized to the multimodal screening, the CO1 to 5 interpreted with the risk ovarian cancer algorithm, they also had longitudinal samples. So if you can see, also in the cohort, we have the initial sample at recruitment for all the women in the control and ultrasound group, and longitudinal samples for the 50,000 women who were in the multimodal arm. So what are the national routine healthcare data set? And probably just expanding on what Professor Peake has already outlined at the beginning of this talk is the cancer registry and the death registers, and then the hospital episode statistics covering England, or the patient episode database for Wales, PEDOA, as well as the National Cancer and Research and Analysis Service, or formerly the NCIN. So the NCIN also has data sets on systemic anti-cancer therapy, radiotherapy, diagnostic imaging, and also patient-reported outcomes. As previously mentioned, there is the Clinical Practice Research Data Link, or CPRD, of the primary care data, and various national audits, such as, for example, for lung cancer data audit, which is part of the NCRES dataset. There are also pharmacy prescriptions, and we haven't connected to those, so I'm not going to give any more detail on those. But just to say, as the trial is still actively running, so we have reported our initial mortality results in at the end of 2015, and we are now in the long-term follow-up of the trial, still trying to answer whether ovarian cancer screening can save lives. So when we say linkage up to 2020, that is as of now, because we have completely linked the cohort from 2001 till more or less this month. So what the data we have is the cancer registry and death notification for England and Wales. In Northern Ireland, the cancer registry and death notification come from two separate bodies, either the Northern Ireland Cancer Registry or the Business Services Organisation. The hospital episode statistics, or HES, covers England and includes the inpatient, outpatients, accident emergency and critical care dataset, and the equivalent PEDOA in Wales. We had also connected to the NCIN data, and we have the coverage or the data up to 2014, and for the purposes of ascertaining outcomes for collaboration, the UCLub collaboration, we have actually worked with the Myocardial Infarction National Audit Project, MINAP, and we have done some of that work in collaboration with Professor Denaxis for the interpretation of the myocardial phenotypes. So just to say, to include that this is a large scale trial with a complete electronic health record linkage, longitudinal unique set of samples with broad consent, and the samples that are fit for all sorts of omics technologies. And this is, as some of you would know now, separated from the main trial under UK LWC, or the UK CTOX longitudinal women's cohort. And if you need more details, I have included a link here. But what I wanted to come back to is really what are the challenges, opportunities of all the linked data that we have had, and how we will sort of address some of the questions we already raised. So we have, it's a very, very busy slide, but what I want to draw your attention that we have explicit consent from each of the 202,000 participants. However, because we recruited women between 2001 and 2005, at one point it was felt that our consent was old when we were requesting medical records to ascertain ovarian cancer diagnosis. So in addition to consent, we have section 251 approval for access to medical notes for the entire cohort. As I said, we have linked to various databases, and we have postal questionnaires and samples for suitable for across the omics technologies. But what are the opportunities and limitations of using this healthcare routine data is the access to the data. So as those of you in the UK would know, the data would be sourced either from NHS Digital or Public Health England, and their particular request forms that need to be completed for this. The completeness of the data. So when we talk about cancer registry, the data that we are provided are the International Classification of Diseases 10 codes, morphology code and diagnosis date. However, stage and grade data is not available nationally. Then is the accuracy of data. So if you, depending on what is the question we are asking and how accurate we would like the data sources to confirm our outcomes, how many sources would we use? Is cancer registry data sufficient? Would we need to do we supplement it with HES data, and when would we do that? And there's then the timeliness of the data. In our own experience, some of the delay in cancer registry notification could actually be supplemented by HES data. And there's a cost, and the cost depends on the data set. But I guess one of the main challenges is the time to having the access to the data and having the linked data within, I guess, the span of the project and all the work that we do. So I'm not going to go into too much detail. Some of the studies, all the studies and all the collaborations that we have done within the trial really are based on the linked data from obviously the cancer registry data, the death notification for our primary outcome, but also as all the women were apparently healthy, postmenopausal women who were randomized to the trial following the entry, they would have developed a number of cancers and number of diseases, and some of the ACED members are already working on answering some of the questions in more or less the non-ovarian cancer sphere. But if we look at some, I'm giving a couple of examples here. One study from way back in 2012, looking at how reliable cancer registration data is if it's compared with the clinician confirmed diagnosis, and for breast cancer, which was the study we did, it's pretty complete. When we looked at much later on at colorectal cancer ascertainment through cancer registry, HAS and self-reporting, we find that cancer and death registrations are a reliable source, but that hospital episode statistics may supplement in a number of women in the cohort. What are the data governance arrangements for routine healthcare? So all our data is stored in the UCL data safe haven, and the access is only given to the researchers who are named on the DARS or ODIA applications, or NHS Digital or Public Health England application. And data that's used in collaborations only with the UKLWC team who have access to the raw data, and only processed data can be used in any collaborations, but onward sharing is not permitted. So this is one of, I guess, the issues that has been raised previously. And what are the specific opportunities for ACED Alliance members? We have a process of contacts, so very similar to what Professor Holmes was outlining, initial contact, and Sofia Apostolidi, who is on the call, is our senior biobank coordinator who will sort of guide through the application and whether we have the samples of the data suitable for any of the analysis. Then there's a data access committee, and following approval, we have obviously all the necessary arrangements for the ethical approval, because all the samples and data donated to, by the women can only be used in ethically approved secondary studies. And then obviously there are the contracts and the material transfer agreement arrangement. So this is sort of the potential of the cohort. It's similar in size to UK Biobank, to the female component of UK Biobank, which is somewhere around 270,000. So our cohort of 200,000 does complement its complete health linkage, and it's even longer follow-up than UK Biobank because we started in 2001. So more or less 20 years of a linkage and successes and challenges of the linked data. So with that, I'll stop and would welcome any questions.
Thank you very much, Alex. That was a really interesting overview of UKC talks. It was new to me. I think it was probably new to many people. So thanks very much. Really interesting. Are you aware of any studies that have used UKC talks for cancer early detection, or studies that are perhaps in progress?
So we have had in excess of 60 collaborations since the trial began, or probably following the end of recruitment. So since 2007, the effort has resulted in about over 65 papers. So most of those, if not all, would have been based on ascertaining cancer the cancer diagnosis and outcome using cancer registry data in majority of them. And in saying that we have over 65 papers, but just under 50 are actually cancer, because our cohort allows also looking at chronic diseases. And as I said, we are part of Ellrott, so looking at myocardial infarction, looking at cardiovascular disease and a stroke. But we currently have an active collaboration with Cambridge, with Dr. Jamie Blundell and his team, and also another one in discussion with another ACED member. So I think it's we would welcome more of the ACED members using the sort of the resource, both the bioresource and the data resource, because the women have given their time and effort and their willingness for sort of not only addressing ovarian cancer screening, but also many other questions that we can address using.
Yeah, and that's actually, I think, a very good point. I considered discussing public opinion and public trust in my talk, but I decided against it in the end because I didn't have enough time, I felt. But it is an important issue around the use of routinely collected data. And one of the consistent findings, I would say, from many studies is that whilst in general, there are people who are, well, at the very least on guard when they are being asked, is it okay if your health data are being used for research? But typically, when you ask cancer survivors that question, the large majority of them would say, please do, please use my data. I want my data to be used. So I think it's a really good point that you're making there.
So in addition to that, we on our data access committee, we have a UK CDOCS representative who represents also the views of the women and what the samples and the data should be used. So we get the, in a way, it's not a patient's voice because the women were apparently healthy postmenopausal women, but we get the volunteer to have a say in how we use. And when we first approached the representative, actually it was very, very positive, and it's the view of the women at large that they have given us their time. If they could help in any way, then that would really sort of make them happy and satisfied about the time that have taken, especially those that would have taken up to 11 annual screens. And as we have centres in North Wales, some of the women would have travelled 60 miles each way just to come to the appointment. So I think they feel quite strongly that it should be used wider than UKC talks.
Yes, definitely, definitely. Right, thank you very much again, Alex, for a really interesting talk. And I think I completely agree that this is a really valuable resource for the ACED community. So hopefully there are people on the call who will take that forward, and well, they will know how to reach you.
Thank you so much.
So we're going to move on to the next talk, which is going to be provided by Lorena Escudero. So Lorena works at the Department of Radiology from the University of Cambridge School of Clinical Medicine. She's got a background in physics, and her research focuses on image analysis and machine learning for cancer research. And the, well, quite intriguing title of her talk is Easier plus Faster is Earlier. So with that, I'm going to give you the floor, Lorena.
Yeah, thank you so much for the introduction, and thanks for the opportunity of being here today. It's been really a great pleasure to hear the talks that we had today. Let me just share my screen and check that everything works. Hope you can see that title right now.
Yes, we can.
Okay, perfect. So yeah, I'm going to talk about this, making things easier and faster to hopefully detect cancer earlier, and doing so by integrating image analysis framework we are working on into screening programs. So first I have one slide to introduce myself. I'm a physicist. I actually have a background on particle physics, which might be a bit uncommon, but actually has a lot of synergies because I spend a lot of time working on pattern recognition, image analysis, machine learning, and AI. So now I'm trying to translate this into cancer imaging research. And for that reason, I joined the Department of Radiology, in particular the Radiogenomics and Quantitative Imaging Group led by Professor Evi Sala in Cambridge. And I'm also part of the ENCITA project, which I'm going to talk a little bit about now. So ENCITA stands for National Cancer Imaging Translational Accelerator. This is a CR UK funded accelerator that will establish a fast and robust pipeline across multiple institutions in the UK to produce quality assured lockdown imaging biomarkers. So this is bringing together 7 institutions across the UK in order to standardize and to build this pipeline across all the institutions. So it has different units for QA/QC, for trial units, and one of the units is the repository one, which is the one I work on. And as part of this repository unit within the ENCITA team, we are building some nodes of imaging repository in some of these institutions, and that we are going to connect together via an XNAT federation. XNAT is the software we use. I will show you a demo in a few slides afterwards. And this will allow us to basically be able to search across data that is held by different partners that is located in different positions, geopositions. And we are a team of at least one person from each one of these institutions who is working into this project and this repository, both at building this infrastructure and also at developing tools for example, the federation that we need to connect them, that is work done by Chris in King's College. So this is basically a bit of the background. I recommend you check the website if you want to learn a bit more about what we are doing. Today, I'm going to focus a little bit more on what we have in Cambridge, because it's where I'm from and where I work on myself. So in Cambridge, we started in January this year. So we've basically had no hardware or anything to host this repository. So we all started from scratch, and we decided to build it using cloud services from our high performance computing department of the university, because it's highly scalable. We can hire resources as we need them as we go. We can increase our virtual CPUs, storage volume, etc. So it's fast to set up and it's easy to maintain. And we are doing work on different fronts, for example, to extract images directly from PACS to put them into our repository. And we are already, since January, hosting around 20,000 clinical imaging sessions for cancer and also for COVID, because as it happened, this affected our lives in the last month. So it also affected the research of our collaborators a bit as well. But it's quite interesting to also see how we managed to get these data sets as well. This, I should say, contains only anonymized or de-identified images. That's one of the reasons why this is different to, for example, your PAC system. This is a repository of already de-identified and curated data set. For the moment, nothing is public. Our projects are all private, and I will show you as well how this works in case you're not very used to XNAT. But another interesting thing is that it allows us to run containerized software and plugins that allows us to basically run exactly the same software, make sure we're running exactly the same software in all the data that we want to analyze. And an important thing is that it's also available 24 hours, 7 days a week. Yes, all you need to access it is a web browser and a decent internet connection, which I think it will be one of the features that will help us a lot to make this used widely. So here is a demo that hopefully you can see now the video moving. So, well, this is just the dashboard of the software that runs the virtual machine. So basically here is where you can select and expand how many cores you need, how much storage you need, etc. from the cloud services of the university. You can also decide the topology, where you want your routers to be, where you want your repository to be accessible from. And then this is just Chrome, this is just a data browser. You can open the URL, and provided you are a registered user, you can just access the repository and the dataset. Probably you have heard about XNAT before, so this is basically what it is, but in case you have never encountered it, I thought it would be interesting to have this demo. So this test user doesn't have access to the data he or she wants to access, so it's now going to request that access. So that's one of the important things of using the system, is that you can decide who accesses which type of data on a per user basis. So now the user requests the access, logs out, logs in again, and we'll have access to that data. This is simply an MRI brain set of images that you can find in the CIA, just as an example. So now it's able to access, the user is able to access, and you can see that subject, that experiment. In this case, it's an MRI session. And you can visualize this data directly in the repository. This is thanks to the OHSU Viewer plugin. That is, it's a plugin in XNAT to use the OHSU Viewer. This is work done by ICR. So some of our collaborators in NCTA work actively in developing this plugin and making updates to it. And you can also make segmentations. You can draw contours around it directly in this viewer, as you are gonna see here. This demo is done by me. As I said, I have no background in any medical related field, so please don't judge my segmentations here. It's just as an example that you can see. You can perform this directly in your web browser and export and save it as the standard DICOM format, either DICOM-RT or DICOM-SEG. So this will now, yeah, well, it's now exported and it goes out, and we can see that it's there. Another point that I mentioned is that, in addition, using this system allows to run containerized software, allows actually also to run deep learning and machine learning analysis tasks directly reading the files from the repository. So you don't need to get the data downloaded. You can use their Python interface and add this to your Python software to run your deep learning or your pre-processing for deep learning machine learning algorithms. So this is something I'm quite pleased with the interaction we have had recently with our collaborators in the Department of Maths, because they can simply use it as if they were reading the data from a hard disk, basically. And you can containerize your software and basically have a single click execution of standardized pieces of software that you build and provide as a Docker container directly from the repository just with one click. And one of the things we are working on, and this is a video from my colleague Mo in Imperial, it's incorporating AI-assisted annotation and segmentation tools as well into the viewer. So this is a collaboration we have with NVIDIA developers and something that we are testing and validating. So, but it's here in this demo that you can see by providing a few points around the spleen, this automated segmentation is going to be performed. Now it's improving it by adding a few more points. It's also done by a colleague who is not a radiologist, so also don't judge the final product. But the idea is that at the end, in less than a minute, you have a segmentation of the whole spleen, the whole 3D segmentation of the spleen. So this is work in progress, but this is something we are actively working on to provide these tools because we believe they will be helpful, and in particular, they will save time to radiologists, which will make things faster to analyze. And trying to join these things together, one interest that we have specifically in our group in Cambridge is to think about if we could use this type of framework into screening programs. So I think, hopefully I have convinced you that this is something that is easy to access. You can upload the de-identified data to the repository from anywhere where you have a browser internet connection, and you can also view it from there. So it's something that could be accessible from mobile units, and it's also fast to analyze once you have the software tools directly incorporated, standardized and incorporated into the repository tools, which hopefully, as I said, is something that can be accessible from the mobile units for screening program, and will hopefully help in early detection. But so the future plans is what do we need now to do? And obviously we need to integrate, well, we need to first of all develop algorithms to automatically detect cancer in the images that are taken in screening programs. And I'm thinking specifically in about non-contrast CT, which has the challenge that is more difficult to detect than contrast CT, contrast enhanced CT. And once we have some set of algorithms developed, integrating it into the repository tools would be hopefully straightforward, very easy. And then we are interested in thinking about how to assess the feasibility of this working in a real screening trial, in a real screening scenario. So answer the questions such as, can it be used in practice? Can the mobile units access? Do they have time to process the images they identify, upload them? What are the potential bottlenecks to make this possible? And then, of course, we need to develop the algorithms and we need to test them. And as I said, they are more challenging than with contrast enhanced images. So we need to assess how well these algorithms perform to finally assess if it's actually feasible, if we can find enough cases in the target population. So to do this, we need to collaborate with the screening programs, which is something that is a work in progress at the moment. And I have a final shameless advertising slide in which just wanted to mention that there is a PhD proposal, a project proposal that is now open here in Cambridge in the ACED webpage. You can find more information. It's for a collaboration, it's to develop these AI algorithms, and it's in collaboration with radiology and with the Department of Maths. And that's all. Thanks for your attention.
Thank you very much, Lorena. as the previous talk, I think really interesting and good for the community to be aware that this resource exists. I think many people in the audience weren't aware. I wasn't aware, certainly. I'm conscious of time, but just going to read out one of the questions in the chat to you. From Sue, a colleague of mine from Manchester. So is the plan for the NCITA image repository to be made available to other image analysis researchers and AI researchers?
So part of the idea is that the data at some point or some of the data will be made public. At the moment, we just started this year to really collect data. So the projects are kept private and only the collaborators have access. As part of NCITA, there will be agreements between different institutions to have access to the different data. But at some point, the idea is in the future, some of the data might be made public, but we don't have a specific plan yet.
Okay, thanks. I guess perhaps once the data are made publicly available, that is something that the ACED community would certainly be interested in. So if that happens, maybe you can let the community know.
Yeah.
All right, thank you again. We're going to move on to our final talk of the workshop today, which is going to be held by Kyle Ellrott. So Kyle is assistant professor in computational biology at the Oregon Health and Science University, and Kyle works on the integration from data from large cancer cohorts. So with that, Kyle, I'm going to hand over the floor to you.
Thank you very much. Okay, just bring this up online. Okay, yes. My name is Kyle Ellrott. I work at OHSU, and I just wanted to kind of provide some experience or perspective about building data commons as seen from more of the research, genomics, and imaging side of things. So I think a lot of talks so far have concentrated on the clinical data sets. Again, the last talk mentioned imaging. We're going to talk today more about, again, large data sets. So when I think about how, data is organized over time, you start out with basically a random directory with file results being dumped into them. So, this would be your sequencing machine is now just dumping files into a directory, and, hopefully there's someone you can email and find out if it's in the home directory. As we start to organize things, data collections start to actually get versioned, made available on repositories for people to download. And so I think a lot of people have seen, data sets that have been released in this format. And then of course things start to get organized and then made available via queryable API. Metadata is actually attached to the files. And so soon you actually have, computable elements that people can actually run code on and query. And then finally you started to get these like very large normalized feature stores where all of the data has been kind of normalized to the point where it's ostensibly queryable and interpretable via high-level API. And so I kind of wanted to describe this, the spectrum of just random data to completely normalized data systems. A data commons has been kind of referred to as one step above of just a data lake. So I think of that term gets thrown around a lot in terms of a data lake. It's to some extent sometimes derisively called, just a dumping ground of data. And so you end up with a set of, a dozen different labs dumping files into a common data store, but with no kind of principle or kind of organizational logic to it. You just end up with random files. And if you want to interpret which files are important for which data or which experiment or what metadata is attached to them, it's kind of, lost in the noise. Whereas a data commons is trying to build up more of a concise and cohesive vision of how the data is not only described, but even processed. And so this could include things like providing standardized mutation calling or feature extraction algorithms to large data files. So as an example of what I'm really talking about is there's a number of different data commons that have popped up in the past few years in order to support large cancer genomics consortiums. These include the ICGC's data portal, which provides the PCOG data set, which is the whole genomes. There's of course the GDC, which provides the Cancer Genome Atlas, as well as multiple cancer cohorts generated by the NCI. We even have things, data commons for canine genomics, as well as pediatric genomics of the kids first thing. So these are, each one of these provides a number of different high-level interfaces and analyses on top of just providing all of the genomic and clinical attributes attached to the files. So what these things are providing, it's a data submission system in order to make sure that files can get loaded into the system and also described correctly. So it isn't just, an FTP upload where you push a file, you actually have to attach metadata to it. There's a sample selections UIs where external researchers can go in and describe the sets of features that are required in order to subselect the things they're interested in. It's usually going to be download clients. Downloading off the web for extremely large files, and I'm talking like multiple hundreds of gigabytes, you need a dedicated download client to enable that, as well as, feature analytics and queryable APIs. All these things need to be available. So in building one of these systems, you have to there's a number of different concerns, from authentication, authorization, data oversight, modeling, search, and providing compute. So authentication, authorization. One thing that has been nice recently is the distributed authentication that we're seeing. So when you log into one of these systems, they can actually provide external authentication options. So you could even log in with your Google ID or your external provider. So in terms of like when you set up an internal data system at OHSU, we could use either Gmail or your internal OHSU authentication. And when you think about a distributed environment with multiple institutions all coming together, you either have a single system that has to provide, authentication and authorization, or you have to distribute that. Again, authorization is the process by which, once you have identified someone as being who they say they are, you have to then make the judgment of whether or not what operations they're allowed to do. And so there are then complex systems that have to go into place to make sure that if a person is requesting read access to a project or any one of the hundreds or thousands of data elements that are part of that project, that they can actually do that. That connects into, again, oversight. So the traditional model for oversight has been to have a data access committee that reviews all applications. However, recently, I think there's been several pushes to actually move this to more of an algorithmic model. And one I would just mention is like Duos, which actually is a data use ontology system. And so this allows the data providers to describe the different data use characteristics they would allow. So is this allowed for reprocessing or open access, combination with other data sets? Each one of these elements is then described as an ontological term, and a requester then defines their research using the same ontological terms, and a matching algorithm will actually do this. So this can help speed up and sometimes been a bottleneck of accessing new data sets. So once you've made the data available and people can get into it, you have to start thinking about, like, what is this data modeling concept? So there's, of course, the structural elements, the project organization, there's the patient sample descriptions, and then there's all of the files that are attached to them. So this is, of course, at the top level of the attributes attached to files. And so when someone uploads the files, they're going to add submit the data in. They're going to be forced to, when they upload a BAM file, add in the attributes to the thing, describe which project it is, which individual it came from, if there's any linked clinical attributes attached to it. And then once you have done this process, this actually enables the top dashboard to actually provide almost like a faceting shopping cart almost, to allow for selection of data sets. So in the case of like the GDC, you can see here that I'm able to go to their portal and select different data files based off of, okay, does it provide mutation, you know, copy number information? Is it an image? Is it biospecimen information? What is the related tumor or case information that was attached to it? So then I can quickly go into the data system, facet for the characteristics that I care about, and identify a subset of files that are relevant to my research needs. Now, that's at the top level of linking basically a tree of projects, patients, samples, aliquots, down to files that were actually processed from these individuals. At an interesting level, there's actually deeper data models that can be extracted from the files. So VCF files, of course, communicates the mutations in an individual. And from the perspective of a lot of these data systems, it's just a blob at that point. You get down to the point of a VCF file, and at that point, it's the researcher's job to download the VCF file and parse it and identify the characteristics they care about. However, if the system is well normalized and actually has feature extraction at the deeper level, it can start to dig into these files and extract the information out for a high level analysis. And so the VCF file is no longer a blob in this modeling tree, but actually becomes a set of normalized attributes. You know, a sample is now collected to a set of, or connected to a set of alleles. These alleles are then connected to a set of genes. And so once you make that available, this is a demonstration of a high-level tree of information that we've made available in one of our data systems that actually goes from the project level to the cases, to the samples, to the aliquots, to the call set, to the alleles, to the genes, all the way connecting to pathways and literature-derived information. This subset of the graph, once made available to the user, enables a number of different queries. And so we've just kind of outlined a couple where you can count the mutations in a breast cancer cohort, or number of mutations per gene, or identify the most prevalently mutated pathways in the cohort, linking it back to the highly mutated genes, the genes that are described in literature as being associated to differential drug response. And so then, once you've normalized all of the, the information, these sort of queries become very tractable and easy. So even if one of these queries is basically, a couple lines in the system in order to deploy and run. And so you can see that there's this transition of just not only taking a bunch of files and then organizing them, but then making them computable and indexed in such a way that it enables researchers to quickly get at the data that they need in order to do analysis. And so again, when we talk about compute on these systems, I think a very fundamental component is the concept of data normalization. If you think about two different labs producing, whole genome sequencing and then running a variant caller on it, you need to be certain that, if you're going to combine these data sets together, it'd be nice if the same variant calling pipeline was run on both and you weren't actually just looking at pipeline effects. And so part of, the compute aspect of providing the data commons is going to be data normalization, in terms of how, raw data is processed into, controlled data, or I mean more regimented data, and then normalized into more an analysis framework. But then you also need to think about how do you enable, resources for the end users. And so again, as we look across the different data commons that are starting to pop up, what do they make available? So there's the high level analysis widgets, workflow engines, visualizations, and also notebook computing. So again, for the processing pipeline, there is an entire subset of bioinformaticians, computational biologists working on reproducible workflows. This idea of software containerization. How do you describe research level software in such a way that it can be run and rerun on new data sets in a kind of controlled and reproducible fashion? And so again, once you have that data made available in a kind of consistent format, then you have these, you know, ability to develop these high-level analysis widgets where someone can quickly go in and ask very interesting questions, you know, with just, you know, web interface. What is the most mutated gene set or mutated gene in the subset of patients? You know, what was the time of survival associated with this particular mutation? Drug response, you know, in the clinical data. Of course, that only answers a high-level subset of questions. If there's deeper analytics that wants to be done or needs to be done, the users need to be able to import this data into their own environmental interface. So, for example, on one project they're working on for the national NHGRI is called the Anvil project, and so that we're bringing the Galaxy workflow system that has, you know, a number of different tools that are presented in a web interface and made available to the end users on a remote system. So they're able to go into the data system, sub-select the files they care about, and then import them into this Galaxy interface and run standard tools on it. And finally, another you know, method of compute that we're starting to see a lot of is this ability to go into the data system and launch Jupyter notebooks. And so these provide interactive programming interfaces where someone can write code in either Python or R or something and actually interactively interrogate data set computationally or, you know, on the system. Of course, finally is visualization. I think it should not be understated how much compute is required to do interactive visualization. And so if we're talking about having a cohort of slides, how do we take those slides and move them into a visualizer so a person can quickly look at the data without having to download all of it themselves. And that is a major component of this is the data size and cost. And just want to emphasize that if we think about how big data can be for some of these data sets, downloading an entire cohort could literally be, you know, several $1,000s in order to get on your system, as well as take a lot of time. So
Kyle,
when you
to interrupt here, I think yes. I'm just looking at the clock. I'm conscious of.
I'm almost done.
Yeah, we've got just a few minutes left. Perhaps if you could use that time to say a little bit more of how, you know, the infrastructure that you've described here relates to cancer early detection. I think that for the audience, that would be really valuable.
Yeah, so I think the way that this is actually coming from a very different perspective of again, the large cohort, cancer cohort systems. And so if we think about all of the different labs in, you know, the ACED system, we've heard about the clinical attributes. How do we start organizing together the genomic attributes in such a way that we can start looking for patterns? So as, you know, more genomes are sequenced and brought online, how can we start to look at that data and identify, you know, how patterns that are connected to these clinical attributes. And I think that would include, you know, looking at genotypes for early detection, as well as also thinking about how can we pull together multiple distributed imaging sets. So I think, yeah, in the interest of time, I just wanted to, again, kind of introduce the concept of what a data commons can provide and how this system can enable researchers to start sharing data, which I think is the important aspect is how do we not just clinical data, but the omics, imaging, and derived outputs of these workflows. So that they can be shared and made available to researchers.
All right, thank you very much, Kyle. I think you've given us something to think about for the rest of our day or afternoon or evening, depending on where we are on the globe. Thanks very much for your talk. And with that, we've reached the end of today's workshop. I just wanted to mention that the session has been recorded, and the recording will be made available to everyone. So the MCRC staff are going to be in touch about how the recording is going to be shared. Thank you very much for joining today's workshop. I hope it was useful, and I hope it will lead to further collaborations across the ACED consortium using routine health data. I certainly have some new ideas on how to take that forward, and I look forward to seeing you in the future at one of the other ACED workshops. Thanks.